Okay, I guess we'll get started. Thank you all for coming. My name is Dr. Jeremiah Tao. I'm the director of the Oculoplastics service here at the Eye Institute. It's good to see some familiar faces and some new faces. Just by way of introduction, I'm the director of the Oculoplastics service. We have an Eye Institute that you're sitting in right now. We have sort of every specialist for all parts of the eye. And the Eye Institute, this wonderful building you're sitting in, is really here to serve multiple purposes. Number one is obviously patient care. The first level and the G level are the clinic space and the operating rooms, respectively. The second space is sort of shell, and this floor you're on is sort of our educational floor, administrative floor. We do resident and fellow teaching here. We have conferences here for the community, like you all, and then we have conferences for other physicians quite regularly throughout the year. So it's really a wonderful thing that we have here. It was all made possible by philanthropy. You may have heard the news today. There's more money come to UCI Health, the Samueli School of Medicine. And so this building was the first of potentially many buildings. I think this gift will probably spark the rest of the growth. The idea was to really create a medical mall of outpatient facilities on this campus right here. Years ago, there was some talk of putting the medical hospital on this site, but I think there was, after long talks and debates, actually, I think they elected to keep it over where it is over at Chapman and the 5. But right here, the School of Medicine, it is right now and probably will be some new buildings, and then there's a School of Nursing coming. So it's very exciting times for UCI, to say the least. But anyways, so back to what you're here for today, eyelid sags and bags. This is a topic that's very dear to my heart that I take care of every day. The aging face. This is a great picture that's you can find on the internet, just of a split face of the same face, 30 to 50 year progression. And I think this is just wonderful. I try to do it myself, but I've only been in practice for 15 years or so I don't have patients that very commonly have an exact same sort of perspective and size photo. But I did find one of this lady. I don't have her permission to use this, but I thought it'd be okay because she's my mother. So I figured, I teach the residents and fellows, if you ever need a good sequence of photos, just sort of survey your family album. Sometimes you find some good stuff in there. This is about 8 or 9 years ago. It's about a 50-year progression, so it's quite nice. You can see just some normal things that happen as we age. There's just some deepening of just the normal lines around the eyes and the mouth. In particular, I draw your attention to the laugh lines around the mouth area, and then the lines underneath the eyelids are the ones we're going to focus on today. These are the ones that bother everybody. I think everybody has them to some degree. So what exactly is happening? Everybody has very similar anatomy, no matter what your race or background is. And as we age, certain things happen. On the upper lid, the skin tends to thin a little bit. We hollow out a little bit in general. The lower lid, there's a lot of things happening, and it really boils down to the underlying anatomy. There's several, some people just think it's just fat or fluid, but there's more than that happening. There's a series of structures that explain these little lines and rolls on the lower eyelid. We certainly do have some fat. The eyeball sits in the orbit, and the orbit is this bony cavity that has two sidewalls and a roof and a floor. And there's a lot of fat that the eyeball is bathed in. If you've ever seen a cadaver or done a dissection, you'll know that there's just a ton of fat around the eyeball. Some of this pushes forward. So cross section, you can see this is a side view, sort of sagittal, cut from the side if the patient's looking forward. Here's the eyeball. You can see that there is some fat that pushes forward through the eyelid. But why does it suck in right below that? What's that dark circle? This is called the orbitomalar ligament. This is also known as the orbital retaining ligament. It's an interesting structure that explains certain things that happen anatomically. I don't know if you've ever gotten a black eye or seen somebody with a black eye. It actually, the dark bruise actually stops pretty abruptly right at this zone, and this is why we call it the orbital retaining ligament. The blood and heme and all the things that happen when we get a bruise stops right there and keeps things within this orbital confine. So below this ligament, we have another fat pad called a malar fat pad or the cheek fat pad, and so as we age, this tendon, this ligament seems to stay strong and suck in, and then we have fat herniating above and below. So you have this sort of multi-curve and then a dark circle underneath the eye. So people don't say that they don't come in telling me that my orbitomalar ligament is a little bit prominent or my orbital fat is herniating. They say they have bags under their eyes or dark circles. Those are the two common things I hear. I look droopy or look tired. And a lot of this is lower lid, but it also relates to the upper eyelid. When we look or meet another person, another human being, we look them right in the eyes. And this zone is really the the money shot. This is really where a lot of things are happening, and it's where you make a first impression. So around the eyes, again, dark circles and these ligaments and the sucking in creates these depressions that we call the palpebral malar groove, or tear trough deformity is another term. Some people actually get a little bit of fluid on some of the skin rolls called festoons. These two pictures are great because these patients not only have these under eye issues, but also have a little bit of upper eyelid droop. The upper lid on the slide to your left, both upper eyelids look a little bit low. On the slide right, you can see that the left upper eyelid is relatively droopy compared to the right. So we're going to break this talk into two broad components. We'll start with the upper eyelids first. There are a multitude of problems and conditions that can affect the upper eyelids to make them sag or bag. The first, and perhaps one of the most common, is just excess skin. This is a drastic case, but everybody gets a little bit, and there's a certain hereditary predisposition. My eyelids are a type that I'm going to need to probably have something done about them, just the way I'm built, and some of it gets worse with age. I dread the person who gets to do my eyelids as the eyelid specialist, so I tease my fellows that they're one day going to have to be my surgeon one day, and I'm probably going to be the worst patient because I'm going to critique everything they do. The eyelids are obviously continuous. The upper eyelids are obviously continuous with the eyebrows, and sometimes the problem is within the eyebrow. I very commonly have patients say that they need an eyelid lift when actually, in fact, it's the brow where the problem lies, and vice versa. I've had patients seek a brow lift, but really an eyelid lift is more appropriate. Some patients need both. This is a good example of a patient who came in thinking he needed some eyelid work, but pretty obviously it's really just coming from the eyebrow. So the eyebrows are important. The eyebrows really are another site that conveys a lot of things when we speak or meet another person. This is a great cartoon. If you'll notice, the eyeballs and the nose and the mouth are identical in all these images, but just the cartoonist has drawn the eyebrows in different angles and different shapes. And you can see low brows and angled brows convey a sense of anger or disdain or even tiredness, or even you're like someone's upset. And then the shape is also completely relevant. The women in this audience know that eyebrows are one of the key structures. We like to make look sharp, and the angle and height is completely irrelevant. This is a great picture of actress Anne Hathaway with her eyebrows photoshopped out on the right. And this is the picture is otherwise completely identical. You can see what a drastic difference in just her perception of beauty that just erasing the eyebrows out makes. It's interesting to note that not everybody you don't want a high eyebrow in everybody. Women, generally, we have a higher arched eyebrow with a little bit lateral peak. In men, we usually do not want to peak the eyebrow because it feminizes the face. I just Googled the other day, male model eyebrows. If you look at most of these male models, their eyebrows are down to their ankles. They're pretty low. So a little bit of a lower eyebrow is not necessarily a bad thing, especially for a man. Look at David Beckham, sort of one of the classic good-looking men. His brows are possibly into his line of vision. So it's important to recognize there's some gender differences in where the eyebrow should be. But the important point that I'm making is that the brows and eyelids are a continuous sequence of skin, fat, and tissue, and they should be thought of together, and we should properly assess each individually and then together when we really assess someone's upper eyelids. So drooping upper eyelids, is it just a problem of old age? Absolutely not. We very commonly see newborn babies and young children who have a droopy eye. This is an example of a girl who was age 4 or 5 who has a left upper eyelid that just was underdeveloped, or she was born with slightly droopy. There are several different causes. You can be born with it. Nerve palsies can cause it. Old age, or the wisdom and experience is what I like to tell most patients. It's not aging. It's just years under the belt. The trauma, very commonly patients who wear contact lenses a lot. The muscle within the eyelid gets stretched out and weakens. So is this just a cosmetic problem? It is largely a cosmetic problem. People don't like one eye asymmetric with the other one, and certainly droopy eyelids give the perception of tired or fatigue or older age. But field vision blockage is the primary reason we address this from a medical standpoint. This is just an example of just the peripheral field that you might lose if you have eyelids that are down into your pupil. And you may think that if this is your view every day, this may not be that relevant. If you're looking at the ocean, who cares if you can't see the horizon? But if you're driving, for example, The blockage here might impact your safety, not only for yourself, but other people on the road. Think about that blind spot that we already have in our car. If you have hooding of the lateral brow, that blind spot becomes more significant. And loss of field vision is a very interesting problem. Most people don't realize how much of a problem that it is until they are either told or shown and compare. Glaucoma is another condition that we have glaucoma specialists here who take of, and this is a condition that slowly eats away at your field vision. For example, so if you're looking straight ahead, it's just the side vision that you're not really paying attention to. And this you lose without even noticing it. Some patients come in very late in their glaucoma with just a tiny island of vision, and all their peripheral field is gone, but they never really knew it was a problem because it's just one of these things you really aren't paying attention and it comes on so slowly. A droopy eyelid very commonly comes on over your lifetime, so it's something you learn to adapt to. You can certainly overcome these field vision blocks by tilting your head, straining your brow, or moving your head in different positions and moving your eyeball. But it certainly is a problem for many folks. There are other issues it causes. Certainly many patients who have droopy eyelids tilt their head back. They just clear their line of vision, but just a natural reflex. This is a good example of a woman with droopy eyelids that's putting her chin up just so she can see clearly. Very commonly, we recruit accessory muscles that hold the eyelids open. The most common is this frontalis muscle that causes these horizontal lines on the forehead that fire and contract when the lids are droopy. There's a common scenario, patients come in for Botox. They don't like these lines on their forehead, but it's their eyelid that's droopy, stimulating these muscles to contract. Here's a familiar face that I don't know if that quizzical look is due to his eyelids being droopy or other reasons, but he certainly has some horizontal lines on the forehead. So back to the head tilt and the neck strain. This is an interesting thank you note that I got. This is in my office. This is a patient, you can't read it, but one of the lines, it's all I did was just a little bit of an eyelid lift. And then I don't want to say that this is an everyday type of scenario, but very commonly patients have other ancillary orthopedic sort of issues that are related to just this posturing. This lady swears that her sciatica improved. This is a dramatic case. I don't get comments like this all the time, but very commonly people do notice a little bit better feel of their neck and their posture and things like that, just due to this just compensatory head tilt or just strain on their neck. Migraines are another problem that are very real. You've probably heard about Botox for migraines, and in a lot of my practice, a lot of patients are straining their eyebrow, and the strained muscles on the forehead sometimes is related to this migraine and just deep ache, and that's why Botox sometimes helps with that. It paralyzes those muscles. So what do we do with an eyelid droop? How do we go from point A to point B? This is a nice post-operative result. It just boils down to the anatomy. You have to treat the correct pathophysiology. In this case, for example, we're not really dealing with fat or excess skin weighting it down like that other picture you saw earlier. In this scenario, the muscle was just weak or underdeveloped. And so in this scenario, we go into the eyelid and find the precise structure that is abnormal. And in this case, it was this levator aponeurosis, or the levator muscles, which is the muscle that cranks the eyelid up. And in most of these ptosis repairs, we just tighten the muscle with sutures and can usually get good results. In other patients, it's more just excess skin issue. That young girl, for example, no excess skin was taken out. We just tightened the muscle within. In this patient, only taking out excess skin achieves a much more eye-open appearance. This is due to a couple of things. The physical skin itself is covering to some regard, but the excess weight of the skin and fat is weighting down the upper eyelid margin to make it a little bit lower. So when we take that weight off, the eye comes up. The brow, this is the same gentleman you saw earlier. If the brow is a problem, cutting on the eyelid, taking skin out on the eyelids would probably not make him much better. You can imagine that little bit of skin you see underneath those brow follicles isn't going to solve the problem. And in fact, for this gentleman, taking the skin out on the eyelid might bring the brow down lower. If you think about taking skin between the lashes and the eyebrow, we're shortening that distance. So in this case, we lift the eyebrow with what's called a direct brow lift, an incision right above the brow. So this is a good example of a direct brow lift, how it works well. We don't like this incision very commonly because it leaves a visible scar in the middle of the face. We're very, very selective about who we make this incision. It's usually a gentleman with deep lines in the forehead and also with really bushy eyebrows. We can hide this incision. In women, we very commonly just lift the whole forehead at or behind the hairline. There's different techniques of using endoscopes and other fancy instruments, but essentially we raise the entire forehead to lift the eyelid and eyebrow area. And you can see on the post-operative on the right, you can see she has the little space between the eyelashes and the eyelid fold. That's known as the eyeshadow space. I think women appreciate that. The men don't know what the heck I'm talking about, but it's just that eye fold that is sort of desirable if you have a Western eyelid. So moving on to chapter 2, lower eyelids. The most common sag in the lower eyelid is something called ectropion, where the eyelid turns away from the eyeball, and multiple causes. The most common is just weakening of the ligaments and aging. Another very common scenario is a Bell's palsy. Some of you may have had a Bell's palsy at one point in your life. I had one myself as a teenager. I had a little shingles for some reason. I got it on my facial nerve, and I couldn't close my eye for a while. Some of these nerve palsies are permanent due to trauma, tumors, cancers, other variety of reasons, and we have to figure out how to protect the eye. In this scenario where the nerve that closes the eye, that controls the muscles that close the eye is out, the eye doesn't close all the way. So even when one is asleep or blinking, there's a lot of space that's exposed. It can be quite dangerous. So this is a similar condition, eyelid retraction. This is similar to that ectropion condition, but to be semantically, technically accurate, ectropion defines just a kind of turning away of the eyelid, where retraction is a vertical displacement. You can see that this patient, the eyelid's not turned away, but it is pulled down. Now, these conditions can occur simultaneously in the same patient, but to be pure, these are two separate entities. This is a gentleman he thought it was a good idea to go to Mexico to have a $300 eyelid surgery, and I think he figured out the hard way that sometimes cheaper is not better. Just another, so we're in Southern California. This is one of the capitals of cosmetic surgery, so a lot of different types of specialists work on the eyelid. Some of them are very good, but a very common type of patient in my practice as an eyelid specialist is patients who had cosmetic work done by surgeons who just aren't very experienced in and around the eyelids. The lower lids in particular are very, very prone to pull down. There's really not much anatomically holding them up. There are other systemic and other eye conditions that can cause the eyelids to pull down. Thyroid eye disease is another very common condition in my practice. This is an endocrine sort of immune system problem whereby the eyeballs become more prominent. The eyes push out of the eye socket just due to growth of the muscles and the fat behind. So the eyeballs are being forced out. Independently, the upper lid goes up a little bit and the lower lid goes down, but the end result is the eyelids don't cover the surface of the eye and the eyes become dry, irritated. And when you combine a prominent eye with bad surgery, then you have a double whammy. This is a scenario of a lady who had a prominent eye and also had some bad eye surgery. So why is this just an aesthetic concern? No, it's not. Dry eyes is a real medical problem. This foreign body sensation, light sensitivity, tearing, redness, these are all serious conditions. Some of you may have dry eyes, so you know it's more than just a nuisance. This can cause some real problems. When the white part of the eye becomes swollen and inflamed, this is called chemosis. This is an unfortunate vicious cycle problem where that white of the eye becomes swollen and inflamed. That swollen tissue forces the eyelids to not close even further, so this whole dryness and irritation persists, and it's really hard to break this cycle. More importantly, though, the cornea. This is that clear membrane on the front part of our eye that light and things have to pass through for us to form vision on to the retina in the back of the eye. If the eyelids aren't there to protect the cornea, they can get exposed and dry out and scar. More importantly, some of these little erosions just due to dry can lead to a little raw surface, and that raw surface is like a petri dish in some patients. This turns into a corneal ulcer, and this is potentially blinding if someone gets a corneal ulcer. So eyelid malposition is the underlying cause in a lot of these patients. It's more than just a cosmetic concern in a patient like this. This gentleman, I think, just didn't really like the way it looked, but we were more concerned about the lack of eye protection, the corneal protection due to his ectropions, and therefore medically, he needs a repair just to protect the surface of the eye. That same patient we saw earlier, there's different techniques we use, but we can raise the lower eyelid. Sometimes we have to put grafts into the eyelids. It's beyond the scope of the talk to tell you exactly what procedures we do and why and when and what types of grafts we use, but the gist is really there are good surgeries to counteract some of this eyelid pulling down. Again, a post-cosmetic surgery situation is very common here. We very commonly see patients who've had multiple surgeries, and you can see on A and B above. This is after her, I think her 5th or 6th surgery, an attempt to roll the eyelids in. She finally showed up here, and we were able to get her eyelids more comfortable. It's important to recognize these other conditions that we talked about. This young gal with the prominent eyes due to the thyroid eye, trying to treat the eyelid is perhaps not the best approach. This is a prominent eye, sort of like a beer belly. And if you think about a beer belly and a pair of pants, if you just try to do something simple like tighten the belt sometimes causes the pants to go further south. It makes matters worse. So there's other strategies we need to have available to get the eyelids in a better position. In this scenario, especially with a prominent eye due to thyroid eye disease, we actually do something called a decompression of the orbit, where we create room for the eyeball and the tissue around the eye. We go underneath the eyeball and on the inside of the eye to let the eyeball fall back underneath those eyelids. Again, eyelid surgery alone probably would make matters worse for this young lady. For this lady we saw earlier, we put grafts on the inside of the eyelid. She was still interested in seeking a nice aesthetic result. She went in, her original surgery was just to take care of the bags and lines, and unfortunately the surgeon was able to take care of some of the bags and lines, but not at the expense of her eyelid pulling down. So in the interest of trying to restore her aesthetic goals that she went into the first surgery for, we were able to put grafts in the eyelid and re-anchor the corner of the eye and pull up on her cheek to really give her eye better appearance and function. Paralyzed eyelid. This is a very common scenario where the nerve that's damaged just really results in a flaccid eye. That eyelid has no movement at all, and the muscle that closes the eye is completely just non-functional. So we have to think of different strategies. In this scenario, we use a little suspender sort of flap that we developed here on the inside of the upper eyelid to really hike up the lower eyelid to allow it to close. I'll draw attention to the lower eyelid. You see how it moves a little bit when he closes. That's not the nerve function. That's just the way, that's our procedure that we invented. It sort of links it to one of the other eye movement muscles to allow the lower eyelid to come up when they close. So it's one of the better things we've come up with, and this is a real problem, patients with facial nerve palsy. But back to some of the topics that probably piqued your interest in coming here, bags and excess skin. We certainly have a combination therapy type of approach here. This is a woman who has real visual field obstruction due to the excess upper eyelid skin weighting down the upper eyelid, but also decided that she didn't like the bags under her eyes, so we can sort of smooth everything out. So anatomically, what are we seeing here? The surgeries really smoothed out this cheek and took care of that double convexity sort of appearance that we talked about in the early slides, of that depression due to that ligament sucking in. And we just restore that sort of single mound. If you look at your well, I guess, if you look at any young child or grandchildren, if you have any grandchildren, their face has just one sort of mound. It's kind of a full, not too many creases and folds and bubbles in them. It's just one sort of convex structure. This is what I call the finger sign. When the patient comes in the office and says, I want it to look like this in the mirror. We never, I know the procedure that they need if this is the desired look. There's a procedure that we do with that pulls up on the muscle that does exactly what that finger does, and it really smooths out a lot of the fat and excess lines and bags. This is an example of that procedure where we just basically pulled everything up and out. It's subtle, so it looks natural, and it really just smooths some of these lines and excess folds around the eye. This is, on the lower lids, we call this a mid-face lift. We remove and reposition some of the fat, but we simultaneously pull up the muscle, just like that finger was doing for that lady. Just another, now an older patient with this same sort of procedure, pulling up on the cheek flap. The lady we saw before with the double convexity and the ligament sucking in, we can smooth it all up. Every patient's a little bit different. Some patients, we talk a lot about repositioning fat and not hollowing out folks, but there are some patients we do just remove a little bit of fat. This is a good example of a woman who had a little bit excess fat on the upper eyelids and the lower eyelids. You can see just the nice smooth appearance we can give her. This is an older patient that just has bags and excess skin, loose skin, and fat. So sometimes you have to really tailor what we do. It's not just a one size fits all, but in this woman we tightened a little bit of the skin and took out some of the fat. And you can see it really just knocks off a lot of the age. And then the other thing I'll point out, she has some of these other benign lesions. Some of these were a little bit suspicious. We removed those, and that really made her happy also, just taking out these lumps and bumps around the eye. I've only shown you women so far. Is this a procedure only for women? No, this is a gentleman who has thyroid eye disease, and he's already had some surgery to decompress the eye socket, but you can see he has these bags under the eyes, and he's a little bit asymmetric, but after surgery, we can really smooth everything out and just restore his appearance. This is the best before and after, by the way. I changed cameras. I got a better camera for the right, and his haircut's better on the right, and so it's a little bit cheating. But overall, you get the idea. So this last gentleman is, sometimes you can't tell the whole story with just a still photo. You have to turn on the record button and hear what the actual conversation he started. And I just said, just stop what you're saying here. I want to record this just so other people can hear this. He had some eyelid surgery.
Change of life to have this procedure done. I can drive at night safely. I can go out during the day without having to put sunglasses on. I can turn on a light in a room in the dark and not have to close my eyes for several minutes. I mean, it has been really a life-changing event.
So who would have thought that when I went into this field, I never thought that doing eyelid surgery I could change lives, but there are some real serious medical issues that happen that are related to just simple eyelid malposition issues. This is a classic example of somebody who just was resigned to the fact that his eyes had to be light sensitive. He couldn't drive at night, and he had to just pour artificial tears and ointment in his eyes. And with a couple, stitches in the corner of his eye, tucking them up, he really got all better. And it's just a good example of the power of some of the things that we were able to do. So in summary, eyelid sags and bags. There's a whole multitude of conditions. It's not just old age. It affects not only your appearance, but it also affects the function. This is one of the true conditions where form follows function. If it looks good, it usually works better. If an eyelid is out of position, it commonly doesn't work very well. You probably never heard of knew that there was an oculoplastic surgery specialty out there. We're a rare specialty. Most other doctors aren't even aware that there's specialists in ophthalmic plastic surgery, but this hopefully will raise some awareness of why there are specialists who have training in the eye and then plastic surgery around the eye that makes myself and the rest of specialists like me uniquely qualified. GHEI, this is a tertiary care center where we have the full spectrum. We also have primary ophthalmology care, but we have specialists in every single part of the eye. So I think it's a really nice thing to have available when I need a specialist for a different part of the eye. We sort of joke how many different subspecialists there are, but some of these conditions really bring home what we're all about and what we're trying to achieve. So thank you so much for your attention and coming. I really appreciate the turnout. Thank you. So Graves' disease is an endocrine abnormality. The thyroid eye disease is a really terrible name for this condition because it really implies that the thyroid is what's throwing off the eye. It's really more complicated than that. It's an immune system problem that has overlapping problem with the thyroid hormone. The immune system commonly makes the gland overactive, but then there's some cross-reactivity with the proteins around the eye. And in thyroid eye, there are really several different things that can happen. The most common understood thing is the eyes become more prominent, they push out, and the eyelids retract. There are more serious concerns. It is a potentially blinding condition because the muscles can swell, pinch the nerve. But it's surprisingly common. They say 1 in 8 patients with an overactive thyroid gets a little bit of eye involvement. Some patients we label as thyroid eye actually never knew that they had an overactive thyroid. It's not directly linked to your hormone levels in the bloodstream. And it's a fair question because even some endocrinologists, I get these phone calls, they say they don't understand how the eyes can be so inflamed and irritated even though that their blood parameters are completely normal. And it's important to recognize that they're two separate entities that just have overlap with the same immune underlying cause. Good point. They say 9 out of 10 are overactive thyroid, about 1 in 10 is underactive. And again, it's not directly linked to the thyroid, so it's related to the immune system. Another term for it is an endocrine ophthalmopathy as opposed to thyroid. Yes and no. I mean, dry eyes is a very serious complication of any eyelid surgery. Most eyelid surgery, cosmetic surgery, poses a risk of making that worse. Some of these conditions where the eyelid's clearly out of position may in fact be the cause for the dry eye. We've seen that very commonly. Patients were told they had dry eye, but it actually really was that ectropia condition where the eyelid wasn't hugging the eyeball or the eyelid wasn't closing properly. So it really just is case by case. It's not an all or nothing type of thing, but dry eyes is certainly something we very, very seriously try to fish for. Even when patients don't tell us they have dry eyes, we look at the cornea and see if there's any evidence of that, because it is one of the horrible things we can cause for a patient. I would like to say I've never given somebody dry eye, but I've certainly missed some of these blepharitis and dry eyes, and in hindsight I should never have operated on them. And so that's a great point, because that's one of the keys of why an ophthalmic plastic specialist is aware of these other underlying conditions. I mean, there are muscles on the face, and you'd think that you can exercise them. There hasn't been that much good science to show that that's an effective treatment for some of these bags and sags. And we, in fact, do the opposite. We paralyze some of the muscles that create some of these lines. So theoretically, yes, but in practicality, exercising the facial muscle probably wouldn't do much to take care of just lines and bags. Great question. Yeah, that's one of the strongest risk factors. There is a phenomenon where if a surgeon not only, let's say they even undercorrect the eyelid. There's a scenario where they undercorrect the eyelid, but the eye actually doesn't close. It sort of locks it in the wrong position. That scenario happens when a surgeon does not know the anatomy very well and sort of links the crank that opens the eye and links it closed. If it's done properly, if you tighten the muscle that opens the eye without damaging the muscle that closes the eye, the mechanism, it should close okay. But at baseline, because the eye is more open, the window is more open, we can induce some dry eye. So a youthful face is generally fuller. There's a big push to fat. You've probably seen some of these cosmetic advertisements to graft fat into the face and to plump it up. They suck it out of your butt or abdomen and plump it into your face. So the fat that we were talking about around the orbit in the eye, that fat does not tend to grow with or to get bigger with weight gain. It's a different embryological origin of orbital fat versus what's called corporal fat. So to answer your question about gaining weight, probably wouldn't affect the fat in the orbit. I mean, I don't know that just would prescribe eating a lot or eating cheeseburgers to make the face more youthful, but certainly fat grafting is a really popular option in recent decade or so. I think a lot of surgeons are not only putting, you've probably heard of fillers, Juvederm, Restylane, all these. That's the basic concept in that is that a fuller face looks younger. And if you just look at your friends, the ones who tend to have a rounder face look a little bit younger than the ones that have really gone. There's another condition that we treat where a child loses their eye for cancer or trauma or whatever, and we sometimes graft fat from the body just to fill up the eye cavity space. So some of these individuals, as they grow and they gain weight, this still has that memory. It's the body fat there that we've grafted from their abdomen, and so that's a phenomenon that we sometimes see. Another interesting phenomenon related, we sometimes graft the young children who are prepubescent. So if they've had grafts from the buttock area or the different parts of the body that are non-hair bearing at that age, but then as they age, it still has that memory. It still has those sort of progenitor cells that start to grow hair. I saw one patient that had a burn on the face at an early age, and then hit 14 or 15 and had a graft from the buttock area and started having hair coming out of the graft that they use. It's sort of unfortunate. But just back to your grafting fat. The body fat is different than the fat we see in the eye socket. Yeah, right now, so there are a certain number of conditions in medicine where stem cells have some promise. Right now, most things you're going to see for facial rejuvenation and facial work is sort of false advertising and overstating what we can do with it. People will graft fat, saying that there are some stem cells from the body fat that'll incorporate and enhance. I don't know that there's much truth to stem cells in periocular oculoplastic surgery at this point, but maybe in the future we can grow tissue. Right. I mean, dry eye, again, there's a lot of treatment. I would recommend continuing whatever has been prescribed. The probability of you causing any eyelid malposition by doing this is very, very low. I mentioned earlier, patients who wear contact lenses very commonly have a droopy eyelid. So if I see a patient with a droopy eyelid like that young girl, anybody in the teen years or in adolescence, I can almost, or maybe in their 20s or 30s, I can almost always predict that they wear contact. And it's not that everybody who wears contact lenses gets the eyelid droop. It's just that I see them all. The ones that get droopy, they get in. As far as damaging, putting warm compresses on, it's pretty hard to do. There is an important thing about heat, though. I've had patients who were using hot compresses for styes and dry things who have gotten a little bit of a thermal injury, a burn to the skin by overheating the pad. So that's an important consideration. That's one real way you can injure yourself. Very good question. So Medicare drives a lot of the criteria of what becomes medically necessary and what's not. It's not a perfect system because a little bit of droop in one patient who doesn't drive and doesn't really need the peripheral vision is different than another patient who, for example, works as a truck driver or has an occupation that needs that peripheral vision. But Medicare has very stringent criteria on what needs to be present for an eyelid lift to be covered through insurance. And most other third-party payers, private insurances use Medicare criteria. So currently right now you have to have symptoms. It has to interfere with activities of daily normal living. This goes for any sort of medical condition, even cataracts and other things. Your vision has to hit the level where it has to impact your normal routine. The other things that are required are things that the doctor will measure. One is the position of the eyelid in relation to your pupil, the center of your pupil, the line of vision. It's called the margin to reflex distance. The center of the light reflex, when you shine a light in the eye, should be right in the line of vision. And the edge of the eyelid usually needs to be within 2 millimeters of that. The third piece of the puzzle is a visual field test where you sit in a machine and you let the eyelid relax and you compare the peripheral field vision with and without a tape or a finger holding up the eyelid. There has to be a demonstrated significant amount of blockage that is directly attributed to the eyelid. For example, if someone who has advanced glaucoma has a droopy eyelid, I suppose they could say there's really no point in lifting the eyelid because the field is already gone. There's an ongoing debate there, but those are the basic criteria. Each patient is sort of we individually have to assess. Very commonly, I have patients who aren't aware that they have medical. I have to sort of fish it out of them that's impacting their lifestyle. There are other patients are clearly cosmetic that are trying to get Medicare insurance to cover their eyelid lift. And then that scenario, we just tell them this. We don't write the rules. We agree that you have some blockage and droop, but it's just this is one of these things that's on the Medicare recovery audit. They do audit these aggressively. So we take 2 sets of photos. We don't ever charge it to insurance unless it's absolutely meeting all the criteria. Your second question, the longevity, the warranty. No warranties, but a good rule of thumb is 10 years. Anything to take away bags or lift, in 10 years' time, it may come back. And in 10 years' time, we age also, so there's other things that can happen. Then you come back and see me. Yeah, it depends. I mean, there is a limit of what's healthy for the eye. They say in surgery, if you keep on cutting, things finally will die off and not work properly. But you just you replace normal tissue with scar if you operate too many times. It varies. It depends on what the procedure is. I think, I can only speak in like eyelid lifts are in the thousands. It really depends on the type of anesthesia, whether you're all the way asleep. Sometimes it depends on how far if we're just treating the eyelids versus the brow and the face or mid-face. So. Great question. We like to quote 6 weeks, but that's because that covers sort of most everybody. The first 1 week, you're pretty swollen, bruised, looking kind of bad. Up to 2 to 3 weeks. So I really encourage people just to get some movie star sunglasses, to not be out in front of their friends or in social or work. The function, your vision's a little blurry for the first couple days, but most people can read and function. Most people drive themselves. A lot of patients drive themselves into that 1 week check where we take out stitches. Eyelid surgery is usually both eyes at the same time. There is a scenario where we need to patch one eye shut. In that scenario, because people don't like having both eyes completely shut to be blinded, we will do one side at a time, but more commonly than not, we do both at the same time. This is outpatient. You come to the surgery center, go home within a few hours. Yeah, the surgeries itself are less than an hour usually. Very, very rarely do we keep people overnight. Yeah, we like to keep folks out of contacts for the first 3 weeks or so, just because of the pulling on the eyelid to get them in and messing with the stitches and potentially pulling things undone. Yeah, younger patients, you'll know, they have what's called an orbicularis roll. They have a little fullness right under the lashes, and it creates a little bit of fold. Actually, if you look at some really good, really beautiful people, the models, for example, they sometimes have a little bit of a line. It's usually a little bit higher. It's due to what's called orbicularis oculi muscle. The muscle right underneath the lashes sometimes creates a little bit of fullness. The groove on the cheekbone is usually related to just the ligaments and the skin and everything relaxing. It shows up later. But that's a good point. Not everybody, not all young, beautiful people have just one smooth eyelid and cheek. Some people have a little bit of a subtle line. It depends on what the problem is. In that scenario, for younger patients who just have a little bit of what's called, there's what's called a little jelly roll due to the orbicularis oculi muscle. Botox is actually very effective just to weaken the muscle there to make it less bulky. And then fillers, the injectable, I think that has a role in younger patients who just don't like a little bit of the fine lines around the eyes. Those are relatively, I'd like to tell you that only an oculoplastic surgeon should ever do those, but those are fairly reasonably safe. The fillers, there are some serious complications. Fortunately, they're very rare. Botox is temporary, so the worst case thing that happens, I very commonly see patients who've had Botox by a nurse or an outside practitioner, their eyelids droopy, and it happens, and the good news is it wears off in 3 months or so for most people. But to answer your question, who should you go to? It's not so, anything in medicine or anything in any profession is really just someone's experience and having the number of procedures under their belt. It's really not so defined by specialty lines, but that's a good start. I think if you're around your eyes, I'd like every patient to see an eye provider for an eyelid issue, but it's more complicated than that, and there's certainly people who specialize in this field are not very good, and there's people who don't specialize in eyelids that can do a very good job also. Yeah, that is so the under eyes, the bags under the eyes is known as the most dangerous cosmetic target. Anybody who does cosmetic surgery, any type of specialist, knows that the lower eyelids are probably the most difficult and most dangerous, because what I talked about before, there's really not much holding the lower lids up against the eyeball. That is one condition. Under eye surgery, I teach the plastic surgery residents and other ENT and other specialists spend time with me, and they rotate, and I basically tell them to be aware of two things: under eye cosmetic surgery and graves, or a patient with a prominent eye. The prominent eye patients it causes a lot of problems, even in really experienced hands. But good question.
Thank you.
Yeah, thank you so much for coming. I really appreciate it.